Okay, I think we're good to go. Just conscious of time. It's a couple of minutes past 10 o'clock. There are still some people joining us, and they'll be able to do that as we go. So welcome to today's session, Live Longer Better, Liberation After Vaccination. I hope you're all very well. Just a few key things from this slide. If you want to you'll be set on mute throughout the webinar. If you want to set your view to speaker view, the view certainly on my PC is in the top right hand corner, and that way you're able to see the presenters and the slides. A key one is around the use of the Q&A facility. So as people are speaking, if you've got any questions for the speakers, please post them in the Q&A box. If you are able to mention the speaker that you want the question to go to, that would be good as well. Good. Okay. So just to say, my name is Adrian Ledbury, and I work for the Active Partnerships National Team. We've been working in partnership with colleagues at Active Oxfordshire, Samure Gray, and national partners on the Live Longer Better programme. And I'll be acting as your co-chair for today's workshop. For those who don't know, Live Longer Better is a system change program aiming to increase health span of older people and transform the way aging is viewed by embedding the concept of enablement, not care, for older people and those working with them. We've designed a number of support and learning initiatives as part of the Live Longer Better programme, and these national learning events form part of the overall programme. This is the third in the series of national events that are designed as thought leadership events, stimulating debate on some key themes, profiling some of the great work going on connected to active aging, and helping to raise visibility and understanding of this important area of work. Over 400 people have joined the event so far, demonstrating the appetite for this subject and the potential collective impact if we are able to collaborate effectively and create the conditions where older people can indeed live longer better. So thanks for joining us today. We've got over 180 people on the webinar so far from a wide array of partner organisations, including local government, active partnerships, Age UK local, NHS and health partners, care and housing providers, leisure providers, trainers and coaches, local charities and national organisations. So it's great to see so many people. You're all very welcome, and I'm sure you're looking forward to the amazing lineup of speakers that are coming up. So I've mentioned about the housekeeping. As I said, as speakers speak, if you want to post your questions in the chat box, in the Q&A box, we'll pick them up and we will cover as many as we can at the end. We've got a panel session at the end for questions. The chat function's there as well, and you can exchange your details, comments and reflections with fellow attendees. So that's a very quick introduction from me. I'm now going to introduce our first speaker, which is Samure Gray. Muir is a consultant in public health, director of Optimal Aging Associates, and is a massive advocate and inspiration for a lot of the work in this area. Muir is going to provide some context and set the scene for today's event. So over to you, Muir.
Well, welcome to the revolution. This is a revolution that we're starting. This is the end of the beginning. Those of you who've been involved in the first phase, we've started the revolution, and vaccination gives us the next big breakthrough. So the theme for the next year will be liberation after vaccination, helping people recover not from COVID, although we have to address that too, but from lockdown. And I've had 27 reorganizations of health and social care in my time, most of which have made no difference at all. In my lifetime, there have been three important reorganizations which have been transformational. So here's the first one, 1948. I was 4 years old, so I didn't play a big part in this reorganization. And we created a big bureaucracy that was wonderful because it did away with the lottery of being unable to get care if you couldn't pay. And we created the local authorities and the National Assistance Act at the same time. The second transformation was 1990, and that's when the market was introduced. People, particularly Margaret Thatcher and Ken Clarke, felt that bureaucracy couldn't cope and the market was needed. But we now know that neither bureaucracy nor the market alone can tackle complex challenges like population aging. We need bureaucracy for linear tasks like the fair and open employment of staff, and we need the market for things like creating new drugs, as we've seen recently, but the market is not sufficient. And we're now in the midst of another transformation, and it's headlined Integration and Innovation. And it involves both health and local authorities, but it must involve Age UK and it must involve the active partnerships of Sport England. And here you can see some of the key points of the white paper. And it's about populations, it's about inequality, and it's about systems. Systems. And these serve geographical populations. And usually it'll be a thing called the dreadful title, the place-based partnership and the local authority, like Oxfordshire or West Berkshire or Harrogate. And there'll be about 150 of those, and they'll line up quite well to Age UK local branches. Now, our system, and this is the end of the beginning, we've been working to create a system, a set of activities with a common set of objectives, and here is the system objectives that we're working to. Systems are delivered by networks that float beside the bureaucracies. So both are necessary, but networks are of vital importance, and we need a cultural revolution. We need to change the way people think, to move from caring for, meaning doing for, to enabling, to supporting, to increasing physical, cognitive, and emotional activity and well-being. So, those of you who've not been before would like to join the Live Longer, Better revolution. And it's spreading throughout England and will come into its own now we've got the basic networks developed. For the second phase, now we've got networks developed, these are the activities. And you can see a very wide range of activities. Been terrific interest in the use of nature and getting people not only active, but active out. But these won't be directed by us or by the Department of Health or the Department of Environment. There'll be networks. It's a learning organization with different networks taking the lead on these topics. So it's the end of the beginning, and you're now going to hear some of the methods and tools that we'll use. So I'm passing back to Adrian and look forward to the questions and comments. So get busy in the Q&A and the chat box. Thank you very much, Adrian.
Thank you, Samir, and great for setting the context and the background for today's session. Just to mark everybody's card, we've got a few speakers coming up. We'll then have a short break, followed by another speaker, and then we've got the Q&A panel session at the end. So the next speaker is Amy McSweeney, who works for the Centre for Aging Better and is going to talk to us about her work, Understanding Physical Inactivity in People Approaching Later Life. So over to you, Amy.
Thanks, Adrian. So I'll just share my screen now. Okay. So yeah, as Adrian said, I work with the Centre for Aging Better. So we're a charitable foundation set up in 2015, and our remit as part of the What Works network is to highlight the people who are the experiences of people who are at risk of missing out in later life. So one aspect of that I'm going to concentrate on today is physical inactivity. So as an organisation, we use this kind of lotus flower-like image to kind of demonstrate the areas of work that we concentrate the most on. And as you can see, there's a lot of overlap between them. So these are goals that we think are particularly important to people who are approaching later life. And I'll talk a little bit more about kind of the language we're using around people approaching later life in a minute. So obviously we want people to live healthier, more active lives. We've got a little bit of target. We've got targets for each of these, which I'll discuss a little bit more in a second. We also think work is important, so fulfilling work and safe and accessible and adaptable homes, which enable people to take part in their community and to build the relationships that we know are important to them. So that goal I was talking about before is that what we want to do is we want people to spend more years free of disability than they currently are and free of disabling conditions, and to reduce the disability-free life expectancy gap between the wealthiest and poorest people in England. So as it stands at age 65, I'm sure most of you will know, the poorest, people from the poorest decile have approximately 6 years of non-disabled years left, compared to about 12 for the wealthiest, and that's roughly similar for men and women. So our approach to essentially tackling that goal is two-pronged. So there's improving health generally, and also narrowing that disability-free life expectancy gap. So the physical inactivity that I'm going to be discussing today, that is part of the improving health. So that's about a project that we've commissioned a consortium out of the University of Bristol to undertake, looking quite broadly at the experiences and attitudes of people who are physically inactive in this age group. So the age group that we're talking about when we're saying approaching later life, we kind of ballpark it as approximately 50 to 70, but we're well aware that that's kind of not a perfect delineation, and that it's not something that is there's quite a lot of room for movement in there, but we think there's a separate group who kind of we can have the most impact on before they reach later life. So the physical inactivity is part of that programme, and along the same timeline we have an active travel research project, which is looking again at people's attitudes and experiences towards active travel in this age group. And a lot of the work that we do is around identifying barriers and essentially finding out what works and reducing those barriers. So there are also, we're also obviously interested in tackling health inequalities through relationships with the fitness and leisure industry, and additionally with our 3 local areas. So we have partnerships with 3 local areas right now. So that's Greater Manchester, Leeds and Lincolnshire. And so we do a lot of work on how to make sure that we are essentially helping to create messages that land well in localities. Okay, so, oh no. Here we go. Okay, yeah, so a little bit more about 50 to 70-year-olds. So obviously, as everyone will know, is that this is not a particularly, inactivity levels generally rise with age anyway, and we don't have a clear delineation of 50 to 70-year-olds in the data, although we know kind of from some analysis NatCen have done for us that approximately 24% of people 50 to 70 would be classed as inactive, as they're doing less than 30 minutes of exercise a week. And we also know that it's particularly important to concentrate on this age group because we know that people who are the most disadvantaged in multiple areas, in work, in accessing their communities, tend to be people who are unemployed, have a long-term health condition or disability, as well as people from Black and minority ethnic groups. So we feel that this kind of approach in later life group gives us an opportunity to say something about this cohort that's particularly interesting, and we feel that in order to have the most impact over the course of our endowment period, which is about 7 more years, we are looking to kind of get more people to move from inactivity to activity. So that's our concentration, rather than increasing the intensity or frequency with which people who are already active take part in activity. Although, of course, that is still something that we want to do. We're concentrating in terms of impact on that first group. So what we wanted to find out from this research project in particular is essentially we didn't feel that this group was being particularly well covered by the existing literature. So we wanted to know essentially a lot about people's attitudes and experiences, as well as the barriers and motivators that they kind of identify themselves. And obviously, sorry about that. Yeah, so obviously kind of a lot of these are relatively, are not necessarily age related. There's a lot of general things, but we do think that there are enough commonalities in this age cohort to kind of justify loosely grouping them together as as a cohort, really, to say that they have relatively similar experiences. There are things that they're quite that they're likely to experience in this group. So I'm going to talk a little bit about the two ways in which the research team we commissioned have decided to approach this. So already they have undertaken an evidence review, which I'll talk a little bit more about the findings of in the next slide. So yeah, that we kind of wanted to test the assumption of whether this age cohort was particularly well represented in the existing evidence base. And so we were particularly looking at qualitative studies because although we don't feel this group is particularly well represented in terms of national surveys or quantitative studies either, we did feel that we would get the kind of deepest understanding of those individual barriers and motivators through qualitative studies. So generally speaking, we did find that there weren't a lot of these studies, so that we found 13 that either concentrated on 50 to 70-year-olds or included some analysis based on that age cohort. So right now, they are doing qualitative interviews with 60 people, 50 to 70. So that's a mix of people who are, I mean, obviously because it's qualitative, it's not representative of this entire cohort of people who are inactive approaching later life. But we know that some people who say they're active or inactive, when you speak to them, it may be that they're not necessarily qualifying that the same way that we are. So we definitely found that we would get the most value through that channel. So in terms of the people that we're speaking to, we were quite aware of the fact that if you look at national surveys, people who are in poor health generally, so 60% of people in this age cohort who are out of work because of a disability are inactive. And we know that people with no qualifications, almost half of them are inactive. And we also know that there are certain ethnic minority groups who are overrepresented in terms of ethnicity in this cohort. So we've attempted to make sure that we slightly oversample on that side to make sure that we're getting some useful findings there. So, but really, to be honest, although it is obviously age-based, we're quite interested in finding out about people's attitudes and experiences individually and how their relationship has changed with activity over their life course. And one of the things that kind of makes that useful for us is how we expect people to, how people expect their relationship with activity to change over time. So I'll talk a little bit more about that in this. So what can we say so far? So the evidence review that was undertaken by our research team, it's relatively limited in that there wasn't a great deal of data. So what we actually found was we were able to identify the barriers, the gaps in the literature that we want to try to fill some of in the fieldwork. So as you can see here, a lot of the motivators and barriers that people identified are relatively general. They're not necessarily specific to this age group. Health is an incredibly strong indicator of activity levels amongst pretty much all groups. And a lot of people find that time is important across age groups. So one thing that we thought that has come out in the literature already is around the role of retirement. And as you can see from this as well, some people saw this yeah, some people saw the retirement as a motivator, in that the availability of time meant that essentially their lack of time was a barrier before their retirement. But others saw it as kind of demotivating. The fact that they had more time meant that they were less motivated to structure their day to include activity. And obviously we find that to be particularly, it's very personal really, and that's kind of why we need the in-depth research that we don't necessarily have with this age group. Okay, so these, yeah, so the gaps, as I said, are the things that what really interested us about this evidence review was finding those gaps and identifying them. So as I mentioned slightly earlier, is that those 13 papers, those 13 studies rather, that looked at this age cohort, they're all relatively outdated. They're all, they're pretty much all pre-2010. And while that doesn't seem particularly, it doesn't seem too out of date, and I'm sure, and obviously there are still incredibly relevant findings for us, we kind of have to check the relevancy of those previous findings given what we know about how people's lives are different now. So what's relatively well covered by the evidence base is the role of retirement, but we also know that people are approaching retirement in a different way. People are having to work for longer, and some people are choosing different approaches to retirement, such as choosing to semi-retirement or never stopping paid work. And as well as that, there's also people who have never worked outside the home. They tend to be people who have got fewer qualifications, or people who have already left the workplace due to poor health. We really need to encapsulate their experiences in this research as well. So that's relatively well studied, as are specific barriers for people from South Asian backgrounds. But obviously that's something that we want to generally capture people's experiences more broadly from different minority ethnic groups. But there has been some research that's relatively good research. And another one is support from spouse or family community. So that's relatively well covered in the evidence base. But obviously we have questions in that really. Is that we know from Aging Better's research, from data, just national data really, is that people are more likely to live alone now, less likely to have children, and more likely to never marry. So even though that research was only 10 years ago, we still want to check that kind of spousal relationship that people saw as a barrier or a motivator to exercise. So if their partner was interested, they would be interested, or that kind of relationship worked for a lot of people, and we want to learn more about how that works and if that is still the case. So we are hoping to fill some of these gaps in the evidence base, but primarily the point of interest for us is around people's individual attitudes and experiences, because obviously we can speak to a lot of people about their life stage and how it relates to them aging healthily, but we're likely to find, as with all other age cohorts, that a lot of it is dependent on the person's lifelong relationship with activity, the experiences they've individually had, and how they relate that to themselves. So it's obviously the usual kind of people like me can do X, Y, and Z, or as opposed to kind of I can't do X, Y, and Z because of my arthritis or my condition. So we're kind of trying to put some depth in there for our age group and our cohort where we don't believe it exists. So we're expecting this research to be published in late summer, early autumn, alongside, as I said earlier, our active travel research, which will be kind of drawing in a lot of the similar kind of things. So hopefully we'll be able to say a lot more then about what kind of work Aging Better is hoping to do in the future around inactivity. So thank you very much. That's everything from me. So I think I'll pass back to Adrian.
Thank you, Amy. That was really good, really interesting, and certainly we'll be very interested in the results as they come out, as you said, late summer. So it'd be great if you could maybe come back as the results are coming through. And it'd be really interesting to find out about those attitudes and experiences linked to some of the hypotheses that we've got. So thank you very much. That was really good. And just to say to everybody, I can see it's happening anyway, but thanks, and keep posting your questions in the Q&A box. And if you want to name who the question's for, so that's taking shape. We'll take those at the end in the panel session. And I can see that the chat is very active as well. So continue using that for your comments and reflections and sharing ideas. So thanks for doing that. Okay, so we're going to move on to our next speaker, which is Andy Maud. Andy is the National Partnerships Lead in Sport England's health team, and we'll talk about work connected to older people in the context of their new strategy, Uniting the Movement. Over to you, Andy.
Thank you, Adrian, and thank you, Amy. I've also had some sight of the research Amy's doing. It's absolutely fantastic. And I'm looking forward to that being shared in the autumn, and also we'll be looking to share a lot of our initial findings from our active ageing portfolio, essentially that level of practice around what works to tackle and overcome some of those barriers and unlock some of those enablers. So hopefully the timing will all sync up and we'll have lots of great practice and research to be sharing then. I'm just looking at my other screen at the moment because I'm just setting up the sharing the screen. I'm trying to. Just having a couple of problems with my Zoom, apologies. Can anyone see the presentation now? If anyone's able to jump off mute and tell me.
Yeah, all good, Andy.
Fantastic. So, as Adrian said, I'm Andy Maud from Sport England's health team. I oversee our work to support our partnerships that focus on the active ageing agenda, which is focused on supporting older adults to stay active or become active as they get older. Understandably, as we've launched our new strategy over the last few months, I've had a lot of questions kind of asking what this means for the older adults agenda. And we don't have all the answers, and we don't expect to. This is a 10-year strategy, and we're really keen to work with the sector over the next few months to develop the initial implementation plan. And for us, this strategy really is a strategy for the sector as well as it is for Sport England. So I'm hopefully today just going to take 10 minutes or so to share some of the key principles underpinning our strategy, illustrate just at a very high level what this could mean for the older adults agenda, and then provide you with a couple of minutes just to reflect. And I've posed some questions to you at the end, just to provide some input into the chat on what you'd like to see Sport England do to support you with your work around the active ageing agenda. So as I said, it's a 10-year vision to transform lives and communities through sport and physical activity. And I think it's really important, the second box here, this statement, collectively and collaboratively, we need to reimagine how we keep movement, sport and activity central to the lives of everyone. This really recognises that at the moment, sport and physical activity doesn't work for everyone. As some of the research Amy was talking about, people don't necessarily think it's for them, or they can't relate to it, messaging doesn't resonate, imagery, tone, language doesn't make it for them, or some people already think they're active enough. And so really, we're looking to recognise that and address that. And as you'll see, tackling inequalities is now very centrally overt to our purpose. And this is really important because we haven't called out specific audiences within this strategy, and instead, we've been very clear that we're going to focus our time, resources and funds to support those audiences that need the most support. And older adults will naturally fall into this work. If you're looking through the lens of inactivity, older adults are disproportionately more likely to be inactive as they age, disproportionately more likely to have health conditions, disabilities and caring responsibilities, all of which create additional barriers to getting active. And so I just wanted to reassure everyone that though we haven't specifically called out audiences like older adults within the strategy, they very much are at the heart of what we're doing through our focus on tackling inequalities. So this just sets out some of the key principles for how we'll work. As I touched upon briefly just there, investing most in those that need it most is really that principle of universal proportionatism, and that's will support everyone to get active, but really focus the time, resources, money on the partnerships and communities that need the most support, and working with those organisations such as all of yourselves here today that can really help those individuals to get active. And building upon that, the right blend of national and local action recognises that all of you have far better knowledge and insight of the communities and issues and the barriers facing individuals. That blend of sort of people, place and understanding people's lives, you have far, far better sort of knowledge, daily sight of that than national resource and sort of policymakers do. So we really want to blend all of that great local experience, insight, knowledge you have with the resources that ourselves and other national funders have, and the influence and the ability to nudge and change policies. And then the simplest standard essentially recognises that in the past, Sport England's resources, funds haven't always been that easy to access. It can be quite bureaucratic, quite a long period of time to get a small amount of money. So we really want to change that and remove some of those barriers that actually reinforce inequalities. And we've started doing that through the Tackling Inequalities Fund, which some of you may have been working with, where we really try and devolve responsibility and funding decisions to active partnerships and other local communities to use the money where they can see that it can have the most impact without lots of bureaucratic paperwork to unlock the money from ourselves. So this focuses on what we'll do, and this is very much reacting to the feedback we've had throughout the strategy consultation period with all of the sector. Firstly, advocating for movement, sport and physical activity. That's very much continuing with the successful campaigns we've had and providing resources and tools that partners such as yourselves can use to capitalise on them. So join the movement, we're undefeatable, this girl can. But also really trying to change the public consensus and narrative about sport and physical activity, and really making sure that everyone values an active life. And I think that's particularly pertinent in breaking down some of the misconceptions and stereotypes around that getting older means slowing down. And so we've listened to you and heard that Sport England can and should step up on those issues. And so we'll do that and convene partners around that. The creating the catalysts for change at the bottom is really recognising that Sport England has a role to create the conditions for change. And that's putting in place the key things that's really needed to change the status quo. So investing in leadership at all levels of the partners we work with, improving the way we share insight and learning, investing in digital across the sector and build the capacity there through to good governance. And then the 5 big issues are what I'll come on to on the next slide, but they're essentially the areas that you've told us are where we can make the biggest impact on inequalities and inactivity, and where you really see Sport England having a role to step up. Just to draw out these big issues, we're not looking at these in isolation. So obviously, if you look through the lens of older adults, all 5 of them can be very relevant. So Recover and Reinvent really focuses on how the sport and physical activity can recover financially from the pandemic. It's obviously had a very big impact at local levels with lots of closures and clubs not able to operate, but equally recognising that we could build back a lot more vibrantly and have a lot more diverse set of opportunities that work for everyone. And if you just take the example here of someone like carers, at the moment, the way sport and physical activity offered is often very difficult for them to access. For example, if they want to sign up to gym classes, there's always a chance with unpredictable caring commitments that they won't be able to make it. And if they receive a penalty for that, or because they've cancelled and not able to rebook onto another session, that really puts a barrier in there to them taking part in physical activity. So really helping the sector to understand all the different nuances and barriers that those with health conditions, caring responsibilities, disabilities face when trying to engage with physical activity, and working with them to offer a more diverse and supportive set of opportunities. Active Environments really does recognise that some people just don't think sport and physical activity is for them. And so how can we encourage people just to build more movement into their daily lives, essentially physical activity by stealth. Connecting communities is very much recognising that people's lives are very much influenced by the place they live, the people, the peers, friends, families around them. And so really working through those local areas to influence the active environments, to influence how sport and physical activity is talked about, valued, advocate to local decision makers the value of sport and physical activity so that they can invest in it. Positive experiences for children and young people, whilst perhaps not resonating quite as much with the older adult agenda, there's definitely sort of roles there for positive role modelling. So children and young people being active can have a very positive impact on their family and the grandparents there. And then the connecting with health and well-being, really, I'm going to come on to that on the next slide, but that's where a lot of our team's work will be focusing, and that's really trying to make sure that sport and physical activity and the health sector are a lot more aligned. So what this looks like through the lens of connecting with health and well-being is very much, these are sort of 4 of the key themes that we're talking about and have listened to you and will work on, but this isn't everything we're doing, but perhaps this groups nicely how we're thinking about this agenda. So making sport and physical activity more inclusive, that talks to the example I just provided around carers. Influencing others to prioritise sport and physical activity by sharing evidence. That could be working with you to help build the evidence base for physical activity investments in residential care homes, housing associations, local settings. And an example there is we've seen through our work with organisations providing physical activity during the lockdown in care homes that essentially it can have a real impact on well-being of staff, well-being of participants, but also the financial bottom line of those organisations. We've seen reductions in spend on antidepressants and pain relief medications. So there's been a real sort of benefit financially to those organisations investing in sport and physical activity. Working with partners who want to improve people's health to leverage sport and physical activity. That's very much recognising that there's a huge range of different partners that we can work with to tackle this, and really going to those partners who have the trusted reach with audiences, whether it's the likes of Carers UK, British Red Cross when we're looking through a lens of loneliness, to all of the active partnerships and the Age UKs here who have real trusted reach with older communities in the areas that you work in. And then facilitating links between those working in sport and physical activity and those in health. That could be building upon our work around moving medicine to improve the confidence and competence of healthcare professionals to talk about physical activity. It can be our social prescribing work that's going on across the country and how we can essentially accelerate that, improve that. And we're doing work around a consensus statement at the moment with a whole range of different healthcare professionals, insurance organisations, sport and physical activity sector, to try and remove the barrier that often the PARQ creates, which essentially requires people to go and see a healthcare professional if they tick the box that they have a huge range of different health conditions, which puts a real sort of barrier in people's minds that, is this safe for me? Is this right for me? So trying to get to a place where there's a lot more collaboration and agreement around the benefits of physical activity outweighing the risks, and so making a lot more streamlined process to take part in physical activity. And I guess I just wanted to, before I sort of give you a chance to reflect, recognise that we've identified within the strategy a lot of things we want to change and a lot that we want to do differently. But I really did want to recognise that there's a lot that's strong day to day in everything that you do across the sector. There's huge amounts of insight and learning that we can build upon around how to support older adults to get active in ways that are relevant, practical, fun for them. And this sort of initiative that Live Longer Better is creating is a great way for that to be shared, and sort of that practice just continually shared and embraced, so that we don't keep, I guess rebuilding the wheel and build on what's already there. The last 4 years for Sport England has enabled us to test a lot of different approaches in partnerships with a huge range of organisations, Public Health England, Centre for Ageing Better, the Active Partnerships Age UK, and we've seen some things that we didn't expect that we can continue. I think post-pandemic, we've seen physical activity packs, a really popular offline resource, and not just for those who are perhaps digitally excluded or digitally not very confident. We've seen it really helpful with local activation, just to give people the ideas, the tips, the inspiration, the motivation to get active. And equally, we've had a partnership with the BBC running 10 Today over the radio and online, which has had huge numbers listening daily to that. And it's a medium that we'd like to explore more in conversations with Centre for Ageing Better Public Health and others around how we do get more physical activity programs and delivery onto the radio, onto the TV, online to work for people. And as I touched upon earlier, there's some very successful campaigns like We're Undefeatable, Join the Movement that we can keep building on and capitalising on. So that was a whistle-stop tour through some of the key principles of our new strategy and illustrating what that could mean for you through an older adult lens. That, I recognise, is just the tip of the iceberg. There is so much within our strategy, and we're really keen to work with yourselves and with the sector over the next 6 months to develop an implementation plan for what we'll do over the first 3 years. And so on that note, I thought it would be really helpful just for you to share in the chat just some reflections on what you've heard. And I've posed some questions, but the sort of reflections don't need to be just on those. But we'd be really interested in we've set out a very ambitious strategy here. What, besides our role distributing funding, would you like support from Sport England to help you with this agenda? And another question might be how we do make it everyone's business to improve physical activity messaging, experiences and opportunities, and how it's not just rhetoric, but we really do put inequalities at the heart of this work. So I'll look to Adrian, but if we do have time, it'd be great if just over the next couple of minutes, you could just have a think about that and share that in the chat. And then the team will take a download of that at the end of the session and share those with me, and we'll feed those into the strategy development. And I'll also be having continued conversations with Adrian and the Live Longer Better team over the next few months to work out how we best support you with this agenda and how it feeds into the wider strategic agenda. So thank you.
Great stuff. Thanks, Andy. So there's some questions there for you to think about. Please use the chat function if you want to respond to any of those, if you've got any thoughts about any of those. Perhaps, Andy, after the session, we can repost those as well. We've obviously got the mailing list, and we can use that to get those questions out as well, so that we can continue that dialogue and that connection. So thanks for that. And as you said, there's some great opportunities to feed into the implementation planning phase at the moment. So I'd encourage people to get involved in that. And there's so many hooks and opportunities and connections within the new strategy. It's really fantastic. So thanks, Andy, much appreciated. We're now going to move on to the next speaker. Again, just to emphasize to keep asking your questions as you are doing in the question and answer. I think somebody asked about the presentations and the recording. It will be made available to you afterwards. It'll be on the Active Oxfordshire website, and we'll tell you about that later. So we have another presentation, and then we'll have a short break. So coming up is Professor Peter Gore, who's the Professor of Practice for Ageing and Vitality in the Population Health Sciences Institute at Newcastle University. He has got a great body of work connected with ageing and has an intriguing title for his presentation today: What do you expect at your age? So over to you, Peter. Thank you.
Thank you. Good morning, everybody. I'll see if I can catch up a little bit of time. I understand we're running slightly behind. Anyway, I thought I'd start with a provocative question. People ask this all the time when I hear people saying this question, so I thought I'd start with that. So my answer might be, well, take starting a marathon at 89. This chap, Fauja Singh, accidentally signed up for a marathon at the age of 89, thinking it was 26 kilometers, and ran marathons for 15 years. And then stopped and said, been there, done that. He still runs Arthur's Seat in Edinburgh every day at 109. So maybe it's not quite as we think, but there's a more important point here in terms of our attitude, So there's a study called the Irish Longitudinal Study on Aging of 8,000 people. And what it showed was that if people had a negative stereotype of aging, 2 years later, they would be walking more slowly and be more cognitively declined, adjusting for all other factors. So our attitude to aging does matter, and we have lots of bad attitude to aging. So we really do need to start there and try to make sure that we're always saying the right things. Introduce you to the LifeCurve. So this is really kind of, it's sort of rooted, if you like, in WHO thinking. So healthy aging, about functional ability. So the things that people want to do and be able to do. So we spent quite some years, this really came out of people not being able to understand how to talk to each other about older people. And so we built this evidential framework. And just to show you essentially what the idea means, what's behind this is if we take somebody, we'll just call him Bert, make up a name, and there's kind of two journeys that obviously they don't look exactly like this. They can be very bumpy and they can be changed. The really important point is that which trajectory you take in terms of your functional decline. So these things on the left are just things that we do either every day or every few days. They're the things that in a survey back in 2012, people said they'd rather die than not be able to do. But you lose those in an order. And essentially it's this order in which you lose them. So what happens is we can then plot somebody's trajectory. And the difference is that having a better journey doesn't really improve life expectancy. It might do a tiny bit, but essentially it just means, as you can see, the person at the top is still at full wash. The person at the bottom is now getting quite considerable amounts of care. And the point about this list on the left is when you can't do them, you can't live independently. So you will either be in care or receiving full-time care. So that's the idea behind it. It's not more years. You might get a tiny bit, but it's really more better years, or health span as we tend to call it. And if you want to look up the paper, it's free to download. You just type that into Google and you'll find it. Just to pick up that, what you expect at your age, again, is if you just imagine in your mind what age you think people in England, my data is for principally, if you think what age do people start to experience the problem of, say, cutting toenails? And the answer is it's 2% of men and 3% of women at 42. The median age is 79, and yet I can find you a group of women in California who can still reach and cut their toenails at 100. So the one thing about age, or chronological age, is it's a pretty useless marker in terms of where people are and what they might need. There's one other really important thing in the concept in the paper, and it's really about what would you do in order to help people shape their trajectories? Is there an order in which things should be done? And the answer is there is. So the first thing you can do is actually, if you do activity, exercise, we'll talk about that in a minute, but if you do the right things, you can actually stay off it for a long time. Obviously, those ladies in California managed to do that fairly thoroughly. So you build reserve first, but you can also get it back. The body is very responsive to the right kind of reablement or exercise. I'll define what I mean by that in a minute. But that's the next thing that you could do, so get that ability back so you're still independent. There is a role for equipment if you can't or won't do those things. So a simple example might be a walking stick that allows somebody to carry on walking. There's obviously lots of other equipment out there. And then the final thing is, if you can't or won't do any of those things, is you have care, which is somebody doing those things for you. Now, I'm not against care, I'm against premature care. People have the right to make their own decisions, but it's important that they understand that when somebody does something for them, to go back to Hippocrates in 450 BC, it's use it or lose it, and that's still true. So these principles are really important, and at every stage, every point at which we might experience decline, we can make those kinds of choices and decide whether we're going to stay where we are or improve and do the things, and we make those judgments whether we're willing to make that exercise. So you might think that functional decline is something that public services are all about. And we did a survey in Scotland with 15,000 allied healthcare professionals, who are the physios, OTs, the people who would mostly be with older people. And we looked at where they were. And this is what we found. So 30% of them were pre-curve. That was really people having accidents. So physios working with broken arms and things like that. Housework, we'll come back to that in a second. And then you see, and they did tiny little bits of stuff in the middle, but actually we also found that heavy housework, either it was misunderstood or it's in the wrong order. So actually 32% of all the engagement was with people that were pre-curve. And then you had this group of people down the bottom who got quite, essentially were becoming more dependent, quite a bit more dependent on others. And that left a vacuum of help, or at least leaves a vacuum of public help. And we found actually that this lack of professional engagement with people in these kinds of areas, it's not a criticism of it, it's just aren't enough of them. In England, we have 2.58 million over 65-year-olds with an unmet need. That would take a very long time with the resources that we have to clear that. Of course, technically, legally, we don't have to help those people with one unmet need. It would be a good idea if we did, because they cost us about 1.6 billion a year, but we'll come back to that. So the point is, what's happening is, if there isn't good help, then people go onto Google, and we describe it as Google fluff, which is frankly mostly rubbish. Most of what you read about aging is either inaccurate, unhelpful, or just untrue. You certainly get some incorrect advice, and a small percentage of it is good. If you really know how to use Google, and you go into things like Google Scholar and you search for the right papers, you probably will find good stuff. I certainly do, but most people wouldn't. They wouldn't find the good stuff. So then the next question, I guess, really is, where do we spend our money? And we also did this as part of the survey, where we were able to go into 8,000 health records with the help of the Scottish Government, the detailed health records, and measure every pill, every outpatient appointment, everything that happened to 8,000 of our 15,000 participants. And this is what we found. So essentially, pre-curve, it costs about £2,000 per person per year in terms of health costs. And down the bottom, that goes up to about 12,000. It goes up about £640 per person per stage per year, which is where I get my 1.6 billion from people staying at one stage lower than they needed to be because of their unmet need. That's a lot of money. By the way, social care spend about the same again. So we're talking about roughly £1,300 per person per stage per year. So to say that we don't have money wouldn't be true. It's just we're spending it on potentially avoidable care. So that begs the question then, can you really do this in practice? If both, can you stop people going down, and can you in practice actually make them go back? How do you do that? What would you do to achieve that? So why are these numbers? Why are the health numbers that very tightly correlate to people's position? So I've started to look at that. There's lots more work to do, but here's just some examples of what can happen if you do the right kind of exercise. And I use the word exercise. Nothing wrong with activity. All activity is good, but not all activities exercise. And in this context, if we want to achieve certain things, we'll need to do specific types of exercise. So what we found in this, or what was found in this, it wasn't anything to do with me. Here's all the authors. It's been felt for a long time that the exercise might have some impact on Alzheimer's, but most of the studies, if not all the studies, were pretty weak in terms of finding any effect. So what this study did was it looked at specific types of exercise. So they were talking about basically 0.8% of your, or 0.8 or 80% of your 1 rep max. So when you look at building strength in your legs, you would look at 80% of the maximum force that you could apply with your legs. And what they found was, although it didn't affect Alzheimer's, it did affect the impact of Alzheimer's because it protected your hippocampus. So essentially, they said that it was like pushing back the impact of Alzheimer's for at least 12 months post an exercise program. So that the participants in this got 2 years of delayed impact of Alzheimer's. So that was one study. So let's look at a simpler one. So these are brain scans that were done with people in their sort of 20s through to their mid to late 70s. And what they found in this, and it might be under your, I'll read it out for you in case it's under your pictures like it is in mine. In fact, I need to move my picture slightly so I'll be able to see it. So for every extra year you spend in education, your brain is 0.95 of a year physiologically younger. That is actually by measuring the size of your brain and looking at the effect in different areas of the brain. And that's no great surprise. We've known for a long time that education was related to better outcomes as you get older. The really interesting surprise, the only other one they found, was flights of stairs climbed daily, something that we probably most of us do every day. And for every extra flight of stairs you climb daily, your brain is 0.58 of a year physiologically younger, i.e. we can measure that on brain scans. So that's something we probably could all do. I run up hills around where I live now because I can get about 130 flights of stairs in there. If you do the maths, I'm misusing statistics now, but if you use the maths, I'll be born in about 12 years' time because I'm running so many. Of course, it doesn't quite work like that. But anyway, there we go. So here's one that really surprised me. So it turns out that when you do exercise that relates to things that you might do every day, like moving around, you do get much more impact of those. So line dancing is moving around, and in fact what they found here, you'll never get me line dancing, but 8 weeks of line dancing does actually improve self-reported mobility limitations and physical function. So it works. And there are lots of, there's a group based in Glasgow called Dance Sing that encourage people to sing and to dance and move at the same time. And I'll come on to that in a second. So when we look at, so this was a meta-analysis of different sources of evidence and looking at gait speed, and we know that people tend to slow down as they get older, and that correlates to bad outcomes, bad aging. And there were two things that seemed to make a real difference in all the studies that were looked at from this meta-analysis. The first was that 70 to 80% of 1 rep max is the thing that really makes a difference. That doesn't mean working at less than that, if that's what people want to or are able to do, won't have some impact. But if you really want to get the significant change, then you need to sort of push. And the other big surprise was that exercise with a rhythmic component, perhaps line dancing, also was very significant. Balance training, they haven't found good effect on that yet, and the jury's out on endurance training. That doesn't mean they don't have an effect, it's just they weren't evidenced in the papers that they were able to find. So really, really interesting if we get this common theme of actually if you push hard, you get really big impact. And that that's important in terms of what we encourage people to do. Activity also mitigates sitting in front of the TV. Whilst we don't encourage people to sit in front of the TV for long times, actually if they do, provided they do the right kind of physical activity, they can mitigate the bad effects of sitting in front of whatever it is, Antiques Roadshow or whatever people watch all day or something. But so there are things that we can do even when people aren't willing to change some of the habits that we might think wouldn't be good for them. So here's the reference for that, and you'll obviously be able to get access to this stuff later. So just one final point really is the LifeCurve is a free app. We're using it. It goes live next week. It's live in parts of the UK, goes live in New Zealand next week. And what we're really trying to build is a collaboration, an academic collaboration where the academics and the practitioners can get together. We can use data collected from the LifeCurve with the right permissions. I'll show you what that looks like in a minute, but it's allowing us to start to unpack what is working for who, where and why in much more detail, so that we can be more specific in terms of the things that we recommend to people. What could you do as active living partnerships? Well, you remember the vacuum? Well, we need a lot of people to fill that vacuum, and it won't be professionals because we just can't afford them. And there aren't enough of them, even if we could. So if we could get our communities thinking like this and have, if you like, a LifeCurve support community, I'll talk to you briefly about how that works in a minute, but where people are engaging with other people and we know who they are and we know what they're doing, and we make sure that we're sort of confirming this idea of always try to stop declining, get it back if you can, and then only go to these more traditional interventions of equipment or care if that's your choice or you don't have any alternative. And we can then link out to mainstream services and help people refer into mainstream services if they need that equipment or whatever else. But wouldn't it be great to see a mass reable product? These stretchy bands are brilliant. They're really not expensive and they really do make a difference. There's some weird examples of how people use stretchy bands, but these are really simple. We have one client of ours is a company who's bought, I think, 30,000 of these bands to give out to people just to encourage them to do simple exercises. A few final points, really. We need to fill this gap with things. So whatever, there's nothing wrong with walking. It's not the same as exercise unless you do the right kind of walking, but it's still good for you. We talked about dancing. One little thing here, we can meet, we can engage with people at any point. And so we did an experiment with this lady, amongst others, where we used her carer, and we went via the carers and said, would you be interested in engaging with exercise in your home? And she said she would. In fact, the evidence is that 60% would do exercise at home if somebody approached them that way. And what we found was that she went from needing quite a lot of help to just needing help with bathing in 6 weeks with 15 minutes of exercise training in the home from her carer. And you can do your maths on that, £640 per person per stage per year. And 60% of people said they would do that. And that saves you 15% of the care costs, whoever's paying, in 6 weeks. And we think there are lots of little simple interventions. We just need to do this at scale. Of course, you can do it with your grandparents or whatever. You don't have to have a professional caregiver in to do it. But there are lots of these little sort of bite-sized interventions. And in fact, we now have one client who's actually going to commission, they've worked out, I think, how to commission care providers to help people maintain and improve their independence and not just do time and task care. And I think that's really, really imaginative and has huge potential impact for everybody. It's not just we save 15% of the care bill, but it's also these people are more independent. And she talks about cooking a meal for a family the next Christmas after this was taken. I didn't have time to show you the video, but this is her showing what she can do with her legs now. She used to go around with a Zimmer frame, and now she can, I've tried to do what she does with her legs and I still can't. And CQC looked at what was going on here and described this as outstanding work. the original LifeCurve was done on paper. The survey was done on paper. This is the actual office, but it's basically what the office looked like to the people that were doing it. We've made that a little bit simpler now. So if you want to help people measure where they are, there's a free app. It's got specific stage-related exercises in there designed by exercise experts. It's approved by Orca, who approve health apps. And you can also, with the right kind of licenses, you can engage with that and find out what's happening to people, provided they're willing to link with you. They can connect to you as an organization, and then you can see what they're actually doing and see the kind of impact that you're having. And I think I'll leave the questions until later, but thank you. Thanks for your time.
Thank you, Peter. Really fascinating, and kind of demonstrates the impact of some small interventions. Also making the connection to economic benefits and the connection between exercise and health span. So really appreciate your time today, Peter. There's some challenges there, I think, for the sector, people on the call. I think in terms of the reference to LifeCurve, I think that was posted at some point in the chat, but if not, perhaps somebody could put that up, and we'll certainly share it afterwards as well, so that people can get access to it. So thank you once again. Thank you to all the speakers so far. We're going to take a very short break. We're running a little bit behind time, so if I could ask you just to take a 2-minute break, hopefully a bit of stretching and exercise in that 2-minute break. We'll come back at 11:10, and then we've got further speakers and then a panel session at the end. So a short break, please. We'll see you in a few minutes. Thank you.
You're on mute. How are you?
I'm okay. Sorry, I'm literally just appeared, and I just caught the end of Peter's presentation, which looked amazing. I wish I'd heard the whole thing.
Yeah, it is a very, very important development. That's from Newcastle, of course, which is one of the key centres.
Oh, I didn't realize. Yeah, Newcastle's fantastic. Yeah.
So he's an engineer by background.
Right, interesting. So we've got.
You're on mute.
Yep.
There you go.
Okay. Yeah, fascinating, that Peter Gore presentation.
Yep. We're going to get back going. So welcome back, everybody. And over to you, Samir, to introduce the next speaker.
Well, population aging doesn't have many superstars, but Camilla Cavendish is one of them. And this is the desert island book, really. If you had one book to read about what's happening as we live longer, it's Extra Time, written by Camilla. And I'm just going to read a little bit of it to get this style. So she captured the science. So this is a chapter, New Neurons, the concept of neuroplasticity, which was no doctor educated before 2000 has ever heard of neuroplasticity. So she says, at the Salk Institute for Biological Studies in La Jolla, California, Professor Fred Rusty Gage and his colleague Gert Kemperman created a sort of Disneyland for mice, with wheels, balls, tunnels, and lots of other mice to socialize with. And then she goes on to describe the results of that science. So the book captures the whole dimension from science to social. Probably the single most important thing I got from it was the concept of purpose, which Camilla will speak about. And in our system, remember, we've got 11 objectives to promote ability and increase health span, to enable dying well as living well. But one which we just dropped in was to increase sense of purpose. And some of the chat we've had already has been about groups starting to raise money, not just doing exercise, but doing exercise to raise money for, shall we say, the Dorset Wildlife Trust. And I also like competition. And we had a very interesting discussion in the chat as to what would motivate people in Barnsley most. Is it Rotherham they dislike most, or Sheffield? These things give purpose. So Camilla Cavendish is a terrific writer, and I'd recommend Extra Time very strongly. So over to you, Camilla.
Thank you so much, Muir. And Muir has been too modest to say that he himself features in my book. I met Muir when I was researching this book. I've been a senior fellow at Harvard, which I was really lucky, it gave me access to people all over the world. And Muir bounced into my office and told me that he'd walked there, you know, for about 25 miles. And I was completely taken with so many of his concepts, but a key one, which all of you know about, is of course the idea of this fitness gap, and the idea that exercise is part of the answer, or activity is part of the answer. And in fact, one of my favorite studies in the book is a study of septuagenarians in Illinois, America, who started exercising when Jane Fonda was cool, you know, became a fad. And actually now have been found to be 30 years biologically younger than their peers. And they're not running marathons, they're just keeping up activity. And of course, as we all know, that's linked to a sense of social connection as well. Now, I know we haven't got a huge amount of time. I'm going to share a couple of slides, if that's okay. Sorry, hang on a minute. I'm just going to whisk through a couple of thoughts from my book, and I'm managing to fail to do this. And by the way, I apologize, everyone. Thank you so much, everyone, for telling me that our conversation was being overheard. I wasn't going to say anything salacious, but it's good you told me. Hang on, sorry. That's odd. This should be coming up. You can't see it, can you? Hang on. There we are. Nope. Sorry.
Good.
Usually more adept than this at sharing my slides. Hang on a second. Right. Can you all see that? I'm assuming somebody will shout if you can't. So yes, I mean, Mia was very kind about my book. I published this 2 years ago, and it's now selling in 16 countries. I think partly just because it's optimistic about what I call extra time. And I started writing it actually after my father died, and I realized that he hadn't realized how long he was going to live. And he let his horizons become shrunk, really, much, much too early. And in fact, when my mother and he split up, he was in his 50s. And the biggest issue in their divorce was our 2 cats, which he loved dearly and which went with my mother. And he never got another cat. And he lived until he was 85, largely in really good health, without cats, which could have kept him company. And he lived without them because he kept thinking, well, you know, life's kind of almost over. And actually, it wasn't. So I went around the world interviewing all sorts of people about their concept of aging, and met a lot of people like this guy here, who are defying the stereotypes. This is Emil Rattleband, and he's a rather fun, very flamboyant Dutchman. He went to court a few years ago to try and make himself legally 20 years younger. He was 69, and he said that because of his age, he couldn't find work and he couldn't get dates on Tinder. And he said his doctors had told him he had the body of a 49-year-old, and he does look pretty good when you meet him. And he wanted to be legally made 49 by changing his birth certificate. Now, the court said no for reasons you can imagine. But actually, what I thought was he sees age as fluid. He sees that almost in the same way that some people would see gender. And in a way, I thought, you know, why do we have to go to court to try and change our chronological age? Why can't we just change our view of what it means to be 69? And that's partly why I wrote the book, because all over the world, what I have discovered is there are people who are living longer, who are living healthier lives, and they are finding ways to build new systems, new neighborhoods, new networks with each other. The key statistic, which many of you will know, is that the world now has more people aged 65 and over than children aged 5 and under. This is largely thought to be a disaster, of course, by governments which are trying to bribe people to have more children. In fact, it's very good news for the environment, and it's going to be very good news for all of us if we can live longer better, and if we can close some of the health inequalities, which I am passionate about. When I ran the number 10 policy unit, I introduced the sugar tax on fizzy drinks, which was a very, very small step towards trying to tackle obesity. But I absolutely agree with Mia and many of you that we can close many of those gaps in health inequalities if we take proper action. Now, Mia talked about purpose, and this is, I think, fundamental. This concept is ikigai, which I came across in Japan. And if you go to the islands of Okinawa, where people live longer and more healthily than almost anywhere in the world, they have a concept, a philosophy of ikigai, which is really, as you can see from this chart, a balance of the way of living. And funny enough, the Okinawans have no word for retirement. Many of them go on fishing or farming or looking after their grandchildren until the day they die. They also have amazing support networks. When you're born in Okinawa, you have a group called a moai, which is a group of friends and neighbours who are with you for your whole life and who sustain you through. But as you can see, there's a kind of balance of things that take you through life, which we in the West, I think, are not really so good at. And if you can balance what you're good at, what you love, what the world needs, and what you can be paid for, as it says here, you find at the center of this chart a reason for being, ikigai, which gives you an inner calm. And it seems to me, from a lot of the research that I looked at, that one of the things that happens to people as they get older, and particularly when they retire, is that they lose a sense of being needed, they lose a sense of meaning. And that is highly, highly correlated with health outcomes. In several of the American studies, they have found that even things like hand grips and walking speeds are correlated with whether people feel needed and have a sense of purpose. I'm going to tell you a quick story from Zimbabwe on this theme. These are two ladies sitting on what's called a friendship bench in Zimbabwe, which were the brainchild of a psychiatrist called Dixon Chibanda. Now, Dixon Chibanda was sitting in his office in Harare one day, and he wondered why his patient didn't come for her appointment. He discovered that she had sadly killed herself, and he was appalled. He rang her mother. He said, "Why didn't she come for the appointment?" She said she couldn't afford the bus fare to come to see you in Harare. And at that point, Dixon realized he had to change his whole model. He didn't have enough psychiatrists to get out into the villages, but he knew he couldn't go on sitting in his hospital and wait for people to come to him. So he thought, I've got to get out into the villages and take my therapy out, and I'm going to have to train a different group of people to provide that therapy. He established these benches, which are now in hundreds of villages, where you can sit in the open and you can get 6 one-to-one therapy sessions with a trained counsellor. He tried different groups of people to be these counsellors. And to cut a long story short, the people he found were far the most effective counsellors for depression and anxiety were grandmothers. Now, the grandmother is sitting on the right here, and those grandmothers stepped up and they have given thousands of therapy sessions, which in a randomized controlled trial have actually been found to be more effective and have more long-lasting effects on depression than standard hospital care. That's not to say that they don't call the hospital if they see someone who they think is suicidal. There are things they can't do. But I think it speaks to something about the culture that they live in, which has a huge amount of respect for wisdom and experience, something which we sometimes lack. And one of the things that worried Dixon was that when he ran out of money for this project, he thought, oh, the grandmothers are going to give up. Of course they didn't, because what they were getting almost as much out of it as the patients they were helping. they also were getting an incredible sense of purpose, and they were deeply needed. I'll just skip to one more brief story. This is a picture from Holland of some wonderful nurses I met who go around visiting people in their own homes. It's a kind of domiciliary care. The model that they are working in now treats 1 million people in Holland, and nurses are coming out of retirement to work for it. They're coming out of retirement because this is a system that lets nurses make their own judgments about what their patients need, and it lets them give a holistic service. This is not time on task as we know it in the UK. This is small teams of trained people going into strangers' homes, making an assessment, building a proper relationship, and doing whatever needs to be done. If it's making a sandwich, if it's changing their dressings, if it's monitoring their dementia. And the patient outcomes from this service are simply extraordinary. And in fact, they've also saved money because they've discovered that patients really trust them. They don't keep ringing 999 and equivalent services. And there is a virtuous circle here, which I personally believe we could learn a great deal from. And this goes back, I think, to something that Muir was talking about earlier, and something that is very much at the heart of what I think many of you are trying to do, which is work through networks. Essentially, networks are, I think, more important than systems. I've just spent part of last year as an advisor to the Department of Health in the pandemic. I authored an internal report for the government on the future of social care and health reform, which is not public at the moment. But I think one of the things I have come to, one of the views I've come to, is that we can wait a long time for governments to change whole systems. Actually, frequently, what really changes people's lives is individuals and entrepreneurs on the ground taking action. And I've met them all over the world. Some of them are in my book, but building networks and building those kind of support systems that we're going to need, if you remember the slide I showed about the changing ratio of old to young, because the fact is we're not going to be able to depend on children to look after all of us. We're going to need to forge new kind of relationships with peers and neighbours, and we need networks that facilitate that. I think that's all I'm going to say at the moment, because I know I've bumped up against time, but I'm looking forward to being on the panel and delighted to answer any questions. Thank you.
Great stuff. Thank you very much, Camilla. Again, some fascinating insights. Thank you for sharing those. I'm sure your book sales will start to go up as we speak. Certainly, I'll be looking for extra time after this session. So thank you very much. And I think it will pose a number of questions. So I think we're going to move on to the panel. We've got about 15 minutes. So thank you to all the speakers so far. I hope you've enjoyed it. I'm going to hand over to Active Oxfordshire colleagues who have been compiling the questions from the Q&A box, and ask Annie or Deborah to ask the first question, please.
Thanks, Adrian. Yes, and thank you for all the questions coming in. There's quite a few that are coming in, so we can start to pose the ones that we have already, and then colleagues will keep monitoring the chat facility as well. So first of all, a few questions for Amy, but let's kick off with one for Amy. It would be interesting to hear, Amy, about some of the barriers for those who are inactive, or if your findings from your surveys will be available to give us a better understanding of possible solutions.
Yeah, it's a really good question. So we're hoping from this research we will learn a lot more about the barriers for people who are currently inactive, as well as people who, as well as kind of the perceptions of the barriers of people who were inactive and have recently become active. So that's something that we're quite interested in learning more about. So we're hopeful that that's going to be captured by this research. I hope that kind of answers a little bit more about the question. I think it's kind of, we're going to be hearing a lot more about it when we get to the interview stage, I think.
Thanks, Amy. One more question here, and I think
can I comment on that, Annie?
Yes.
We came up in the chat room and it's chiropody. Now, for me, the other part of my life is high-value healthcare, and there are two high-value services I'm in no doubt about: district nursing and chiropody. And what has happened is we've privatized chiropody over the last 40 years. I always say because the people couldn't go on a protest march. So of the essential services, podiatry is an issue. So we will take this up in response to those who commented on that. And another quick thing, if I may, I noticed from the chat room, Camilla is such a good speaker. People were in a trance when she was speaking. So get some good questions down for Camilla as well as the rest of us. So I think podiatry, we will do something on podiatry, and I'll link up with Amy on that.
Thank you, Muir. Yes, and there was, as you said, there were some questions in the chat room and on the Q&A facility. One other one, Amy, if you don't mind, before we move on.
Yeah,
the question here is, if the research is focusing on 50 to 70 age group, have you done any work with employers, as the target population would be working age, particularly with regards to health and wellbeing, retirement help and suggestions, etc.?
Yeah, so we have done work before with employers about retirement transitions, and as well about options that they can take for smaller businesses in terms of what kind of occupational health they can offer. So we've done some things around that, but we are hoping to work on that a little bit more in the future. So we've got a project we're currently working on, looking at people with health conditions in their 50s and 60s and their employment experiences. So we're hoping to have a little bit more to say about people's individual experiences of that. But yet definitely I agree, we are hoping to work with employers. We're a little bit cautious that some of the most disadvantaged in this age group either A, have never worked outside the home, or B, might already be out of work in their 40s and 50s with poor health. So we think that we need to be more holistic about it than that, but it's definitely a really important part of the research we need to build on.
Thanks, Amy. Moving on then, question for you, Andy. It would be good to get support at how we can sustain the provision of initiatives that help people become more active without the need for continuing to look for funding. How do we embed inclusiveness within society?
It's a very, very good question. I don't think we've necessarily got the answer to that, but we're certainly recognising that the way funding models work, both from Sport England and other funders, do make it very difficult to sustain delivery of let's call it an intervention in the medium term. So we're looking at how we make it easier to unlock longer term funding, so we don't just work on project life cycles. Equally, how we can support organisation to really make the case locally so that you can sustain something. So how, if you take the example of physical activity in housing associations, care homes, local health settings, what do they need to see to be willing to co-fund it with us in the longer term, where participants can't necessarily afford to pay for it or don't value it enough to pay for it themselves. So we're looking at models, and we recognise that's a real challenge, but we don't necessarily have the answers. But equally, we're looking a lot more holistically. So how can we ensure that the environments that people live in, work in, encourage more movement and physical activity, so that we're not always necessarily thinking it has to be a physical activity intervention. It just be, how can we encourage people to take the stairs more? How can we move more between the GP and our supermarkets? So really looking at places and the environments and trying to remove some of those barriers to physical activity as well.
Thanks, Andy. I think Muir, would you like to come in as well on that one?
Get a bit of advice from Camilla on this. I think that we are a network, and we float beside the bureaucracies. You have to have bureaucracies, and we're operating. We're sort of in the jungle. We appear, we do things. You might not see us all that clearly. But there is a national level, and I think I'm right in saying that the chair of Age UK has never had a meeting with the chair of Sport England, or and the chair of the Health and Wellbeing Board of Local Government hasn't met the chair of Age UK or the head of the NHS. And we've got to get some connections at the top. One thing, I think we should have a campaign to switch £100 million from the drug budget, which for older people must be about £4 billion a year, to an activity budget. But that there's no point in trying to merge the Department of Culture media and sport, the Department of Health and Social Care. Let's leave them as they are. But Camilla, how could we get a bit more tie up at the top of the, nationally? I don't think of top and bottom, but nationally, we do need to see better connections. Is it the House of Lords? Is that an appropriate way to work, or should we just have some campaigns? How would you advise us to go to take this example? I may not be right, but shift £100 million from the drug spend to the.
I love that idea, except for the fact that your first headline in the press would be that you're cutting the drugs budget. So, you know, that's the politics of that, unfortunately. Look, I mean, many of the people on this call have probably been involved for 10 years in trying to improve preventative health. And we've paid lip service to that for years. And for years, we've said in the NHS, you know we need to move the budget. We know we need to spend more on prevention. And it never happens. And I think one of the reasons, and I saw a question about the sugar tax in the Q&A, which speaks to this, and I want to answer that if I can. There's a huge reluctance to tell people how to live their lives, and which is not wrong, by the way. I mean, you know, I'm not greatly in favour of the nanny state, and I'm sick of people telling me what to do. And I totally understand where that view comes from, but I think at the top of a lot of these organisations, there is a deep reluctance to get involved in lifestyle choices, which sound, if you're not careful, like lecturing to people. Now, that is not at all what any of us are trying to do, but I think we need to tell a slightly different story about this. So someone has asked a brilliant question in the Q&A about the sugar tax that I mentioned, and of course I've realised, you know, we should never have called it the sugar tax, because what the question is suggesting is that the intention of the sugar tax was to hit poorer people with higher prices. That wasn't what we did. What we actually did was we levied a tax on the big manufacturers to force them to remove sugar and crap from their products. And that's what we did. And in fact, as a result of the tax or levy or whatever we want to call it, 30% less sugar is being consumed by people, largely lower income people and teenagers in this country, who buy an awful lot of fizzy drinks. Now, I think that was a good outcome. And the truth is that a lot of people haven't even noticed that. The truth is it's a nudge. You know, we're trying to help people to actually live more healthy lives. And I think we need a lot of nudges like that. But you also have to be open about the fact that, you know, we have a crisis of obesity, we have a crisis of diabetes, we need more activity, and we need to support and encourage. So I think it's partly about the narrative that actually all of you are generating here, which is a positive thing, and it's not negative. So there are lots of ways in which we could bring people together at the top, Mia. I mean, the House of Lords is a bit of a, I don't know, I mean, it's a bit of a red herring, I think, often in these situations, but actually the fact that you've created this network is the answer, because most of the examples that I found across the world are of people getting together to do the right thing. If you go to Pennsylvania, doctors there have created a pharmacy which they call fresh food pharmacy. They're prescribing food. They've given up. They're not prescribing, you know, other stuff. They're taking people who are suffering from severe diabetes. They are actually providing them with recipes and food for 5 days a week, not just for them, but for their whole families. And the only commitment those people have to make is to come into a workshop and learn about how to cook and prepare that food, because they know that those people are living in food deserts where they cannot possibly afford the kind of ingredients that they need. Those are the kind of changes that will transform the system, because the outcomes are so obviously better. So you have got to keep going at every level, because that is how we're going to change the system.
Good.
Thank you, Camilla. I think we have time for a few more questions. Peter, there's been a few questions that are relevant to your presentation. One of them commenting, first of all, that LifeCurve is fascinating research, and noticed that these are all physical activities. What was the impact of social interaction, e.g. group activities? Did you look at that as part of your research?
Social isolation doesn't matter. I love saying that, because it is technically true. Your response to circumstances matters terribly. So if you feel lonely, that's as bad as smoking 15 a day, and that certainly produces poorer healthy aging outcomes. But you can live in a family of 8 and feel lonely, and you can live on your own and not. So the problem is that it's not an objective measure, it's how you respond to circumstances. So obviously, if you go to a dancing group because you enjoy that social interaction, that's also very good for you, and will, if you like, sort of accelerate the benefit or multiply the benefit of the physical activity as well. So most things aren't just one thing. When I go and do the parkrun, it's a social event, not just a physical event. So nothing's usually quite as straightforward as just being one thing. So yes, it really does matter. Social interaction is very important, but we have to understand that it's about what people want rather than what we might think they want. Some of us are higher introverts, and we're quite happy with our own company. We don't need to interact with lots of people. So it's understanding that it's about what people want rather than our perception of what they need.
Thank you. Adrian, I'm going to pose one last question, which anyone from the panel can respond to if you want to manage that response. So the question is to the panel: how far can we link increased physical activity to slower cognitive decline in older adults? Should mental health be given equal weight to physical health when talking about activity and ageing?
If I could start on that. The activity we classify as physical, cognitive, and emotional. Those 3 dimensions. The cognitive has been one of the most interesting developments of the last 20 years, and beautifully described in Extra Time, that the Lancet Commission estimates we can reduce the risk of dementia by 40%. It has already declined significantly. And actually, dementia is the big motivator. Cancer used to be the disease that people feared most, but it's now dementia. So I think the evidence is very strong. Peter mentioned this in his presentation, and I think as a motivator, then, and we also say, as Camilla has said, this is not a lifestyle issue. This is an environmental issue. This is the world we live in now, dominated by the car and the computer and the centralization of shopping. So I think the evidence is very strong, and as part of the second phase of the Living Longer Better Network, the second phase of the revolution is going to focus on dementia and depression. So that's our next year's focus, as well as carrying on with physical. Peter, anything to add to that? You cover that very well.
So activity is very good for your mental health. Probably the only way I survived lockdown for the last year is actually by going out doing runs. Because I couldn't have some of the other kind of engagements that I wanted. So there's clear evidence that links the right kind of physical activity to improve mental health. Again, it's also connects to interactions that you have while you might be doing that activity. But we're not sort of functional beings that don't connect to others and don't have emotions about how and all that kind of stuff. So it's more complex, but I think anyway. So I think I probably made my point.
Camilla, that came out strongly, didn't it, in terms of social engagement and positivity being very important in mental health, practically important in reducing the risk of dementia.
Yeah, and actually one of the things that when I give talks about this, audiences find it really, really hard to accept is that figure from the Lancet. I mean, people just don't believe it. They don't believe that the incidence of dementia is falling, and they don't believe that, as you said, the Lancet Commission suggests that 40% is preventable. I mean, it's the thing that people can't get their head around, but it is a tremendously optimistic prospectus, and we have to keep making that argument.
And Andy, you have your hand up as well.
Yeah, I was just going to say on this, I think definitely it's been accelerated through the pandemic that different levels of decision makers and commissioners in government and elsewhere are seeing the importance of physical activity and mental health. So I think at policy levels, we will see more investment in physical activity for that. But I think we also need to remember that a lot of changing people's behaviours is at that individual level. And many people do know physical activity is good for their health and good for their longer term mental health, but that doesn't necessarily change their behaviors. So a lot of this is around framing the more immediate benefits, if going for a run or a walk for your mood, your sleep, your pain relief. And I think we just mustn't forget the importance of just those immediate benefits, because lots of us don't necessarily take into account the longer term benefits, even though we know physical activity will help us to maintain our independence, continue doing those things we love. It works for some, but not for others. So I think, yeah, just remember those individual framings, and a lot of that will come through the research Amy's going to share. But I noted a point in the chat around sort of not wanting to wait for this. So it's definitely something Sport England are hearing around getting our live learning, that's sort of seeing what practice is working now out as quickly as possible, so you don't wait 6 months to be able to see it and use it. Peter.
We talk a lot about motivation and how to engage people, and sometimes people can be very creative. So I did a presentation in front of some local authority somewhere, and the head of IT went down on a Saturday morning to his group of what he described as rather overweight, unhealthy middle-aged men, making their models, their engineering models. And he looked and he said, "We're aging really badly." So he said, "I need to do something about that." So he said, "Hey guys, why don't we make model planes?" And they go, "Oh, we've never done that. That's a really good idea." And he had a bunch of middle-aged men running down the field, fetching their crashed planes back and getting back so they could have another go while they were still there. And it cost nothing. It was just a genius idea that created, he just understood what would get them going. And we just need more of those ideas. It was just brilliant. And I just wish we could find more people that have that kind of imagination.
Great stuff. Okay, so I think that's a really good point to end it. Thank you very much to our speakers. Some very thought-provoking stuff in there. Thank you to everybody for attending and for participating. There's been some great interaction in the chat and some great questions. So thank you very much. I hope you've enjoyed today's session, found it thought-provoking and valuable in connection with your work. A big thank you to Deborah, Annie and Richard from Active Oxfordshire for running today's session and organising it. Big thank you to you. We will be organising further events like this, which are a great way, as speakers have said, to make those connections, to find that innovation, to find that spark, and to carry on that networking opportunity. So as we develop the thinking and the events, we'll push that out. So watch this space as we firm up the details. So we are at the end in terms of the time scale. So we're going to close the meeting now. As we close the meeting, there will be a survey. And if you're able to complete that, it's a very short survey, but very important for us to hear about your reactions for today and help us shape future events. So we'd really appreciate it if you could spend a few moments to complete that. You can see the details on the slide, and the recording and the presentations will be shared with you. And that's it. That's all from me. So thank you very much and enjoy the rest of the day. Thank you.